So far, we've talked a lot about normal cardiovascular function, which is important to know because now we're going to go into disorders. And I'm actually arranging it in a slightly different order from how it is in the book because I have to arrange it in a way that makes sense to me. So hopefully it makes sense to you as well. And if not, ask questions. So we're going to talk about vascular disorders first. And hypertension is one of the most common things we're going to see in the clinic, even though we're not necessarily treating for that. It's something that we're monitoring a lot. And we should all know about it because there's a lot of it out there in the community. So even if somebody's coming to you for something else, they could also be under treatment for hypertension. So one of the learning objectives is to explain why untreated hypertension is dangerous and to define and explain the term intermittent claudication. So intermittent claudication has to do more with peripheral artery disease. So in this section, we're going to talk about hypertension. We're going to talk about arterial and venous disease. And so it's probably going to be two separate recordings, starting with hypertension. But really, when we're starting to talk about categories of heart disease, there are sort of four main classifications. Vascular, so having to do with blood vessels. Valvular, having to do with the valves of the heart. Electrophysiological, so something wrong with the electrical system of the heart, or cardiomyopathy, where there's something wrong with the heart muscle. A heart failure falls into this range. They're not exclusive. The classifications can overlap. So electrical abnormalities can be caused by circulatory issues, and cardiomyopathy can be caused by any of the other three, or it can be a standalone problem. So it can be super complicated. So a lot of times people that we are treating in the clinic or in the in any setting, they are complicated. People with heart disease are complicated. So that's just something you should know. You're working with people with heart disease. So coronary artery disease. So remember how I said that the first customer, the first branch off the aorta is to the coronary arteries. So the heart is its own best customer. So if your coronary arteries are diseased, that could be a problem. So there are a couple different types of arterial disease that we'll talk about. Arteriosclerosis is one of them. And that is a general term for all types of arterial changes. There are degenerative changes in arteriosclerosis in small arteries and arterioles. There's lots of elasticity. Remember, the arteries have to be elastic to kind of absorb that blood pressure. The lumen, the opening in the artery, gradually narrows and may become obstructed. And arteriosclerosis can be a cause of increased blood pressure. So atherosclerosis is slightly different. It's the presence of atheromas in large arteries. So atheromas are plaques consisting of lipids and calcium and possibly clots. And atherosclerosis can be related to diet, exercise, and stress. So if you have a poor diet and you don't exercise and you're under stress, your arteries could look like the one on the bottom here. So the one on the top is a normal, in the inside of a normal artery, and the openings that you see, those are branches going off, and it's all nice and smooth and pretty, right? And that's really what we want the inside of our arteries to look like. The diseased artery on the bottom, ooh, not too pretty, right? So obviously a surface like that that's all pitted and scarred, clots can build up and plaques can build up there. And so that can cause a problem. So lipids are transported in combination with proteins. They're called lipoproteins. And we generally have two different types in our circulatory system. Low-density lipoproteins, or LDLs, they transport cholesterol from the liver to the cells. They are a major contributing factor to atheroma formation. High-density lipoprotein, or HDL, transport cholesterol away from the peripheral cells to the liver. It's considered the good lipoprotein. So the cholesterol gets broken down in the liver and excreted. So sometimes you're like, oh, you can't remember like which is the good one, which is the bad one. This little graphic kind of helps you remember a little bit. One person told me, their doctor told him, a patient told me this, their doctor said he thinks of LDLs as lousy lipoproteins, L for lousy, and H for happy. So whatever it takes for you to remember it. But the HDL are the high density ones. They're the ones that are transporting the cholesterol to the liver and for breakdown and excretion. And the low density lipoproteins are transporting from the liver to the cells. So if your LDL is too high, then sometimes they want to put you on medications, statins usually. So the risk factors for our atherosclerosis are, some of them are non-modifiable and some of them are modifiable, just like everything. Age, can't do anything about that, right? Gender, genetic or familial factors. So if you have the familial hypercholesterolemia gene in your family, well, you might have to deal with this. Modifiable risk factors include obesity, that can be changed, sedentary lifestyle, that can be changed, cigarette smoking. I know that you all probably know at this point that cigarette smoking is bad for you. There you go. Diabetes mellitus, it might not necessarily be able to be changed, but it can be controlled. So if you have diabetes mellitus, if you keep it under control, you're going to lower your risk factor for atherosclerosis. Diabetes is a terrible disease. It wreaks havoc on your body, but the better controlled it is, the fewer side effects or the fewer secondary effects you're going to have. Poorly controlled hypertension is a risk factor for atherosclerosis. So that's something that can be controlled as well. So sometimes if you have essential hypertension, which we'll talk about in a few minutes, you can't really change that except by controlling it. And that usually means taking medications. So there you go, control the hypertension. And we'll talk about why that's important too. The combination of oral contraceptives and smoking is a bad combination. It's a risk factor for atherosclerosis, and it's a risk factor for hypertension. And add a few more of those other modifiable factors in, and you can be in trouble. So there's some bad combinations. And so non-modifiable, you just have to live with it. Modifiable, you can modify those things. So we don't have 100% control, but we do have some control. So let's control the things we can. I guess that's the takeaway. So atherosclerosis is diagnosed usually by, the first test is the serum lipid levels that are tested, your blood test. It's usually done fasting. So you don't eat for 10 or 12 hours, and they take your blood and they compare. Usually you'll get an HDL amount, an LDL amount, and then they have a combined overall amount. And they want the ratio to be a certain ratio as well. So the treatment for atherosclerosis is weight loss, exercise. We could do that. Lower total serum cholesterol and LDL levels by dietary modification, reduce sodium intake, control hypertension, stop smoking, the anti-lipidemic drugs like the statins, and surgical interventions such as coronary artery bypass grafting if it's really out of hand in your coronary arteries. So in this little graphic, the LDL is dumping the cholesterol into the artery, and the HDL is taking it away to the liver to be broken down and excreted. So that's another little graphic that can help you remember what the individual ones do. So this is just a picture of putting a stent in a coronary artery. So when your coronary arteries start to get those plaques building up from atherosclerosis, whatever your risk factors, you have this narrowed artery, and that can start to cause problems because we're diminishing the blood supply to our myocardium. So that's a trouble right there, trouble brewing. So sometimes they'll do an angioplasty where they follow the artery up with a scope, and Sometimes they kind of just clean the artery out. Sometimes they will place a stent, which is a little thing to keep the artery open. And that's all done through, they pass a catheter up through the artery. So it used to be they would really stent a lot of things. Now they're different treatments and they're not doing stents as much, even though they still do them. If the coronary artery is completely blocked, you might need a coronary artery bypass graft, which is where they take a vein or an artery from another area and they actually bypass the blocked area. So the nickname, or what you'll hear people say in a medical setting, they'll say a cabbage coronary artery bypass graft. And sometimes you'll hear, in layman's terms, you hear someone say a triple bypass or a quadruple bypass. What you'll see in a medical setting is they'll say cabbage times 2, cabbage times 3, cabbage times 4, meaning that's how many arteries got bypassed in the procedure. So if they graft an artery from another area, that tends to last a little longer because arteries are a little thicker and they have better elasticity. And sometimes they'll use a vein, sometimes they'll use an artery. It depends on what you have available, basically. So hypertension or high blood pressure is pretty common. Blood pressure is the pressure of the blood against the systemic arterial walls. And we have receptors in our aorta, baroreceptors, that detect pressure. And they tell the nervous system if something needs to change, basically, to lower our blood pressure. Normal pressure in adults is commonly around 120/70 millimeters of mercury at rest. The systolic pressure is the pressure exerted by the blood when the blood is ejected from the left ventricle into the aorta. The diastolic pressure is when the ventricles are relaxed. So that's the relaxed state of your heart. Naturally, we want it to be lower. And we've talked about in class how the response to exercise is systolic blood pressure goes up and diastolic stays relatively the same. That's pretty important. Blood pressure is going to depend on the relationship between cardiac output and peripheral resistance, how much resistance is in your arteries, and blood volume, viscosity, venous return, the rate and force of heart contractions, and the elasticity of the arteries all contribute to blood pressure. So any changes in your blood pressure are detected by those baroreceptors, and they're relayed to the brainstem, the medulla, to see what has to happen. So high blood pressure is very common. We see in hypertension is the medical term for high blood pressure. Hypotension would be if your blood pressure was too low. High blood pressure can occur in any age group, so it's not necessarily an older person or a younger person, or any age group. High blood pressure is more common in individuals of African ancestry. Sometimes it's classified as systolic or diastolic, so whichever one is elevated more often. Diastolic tends to be genetic. You can't really control it. Systolic can be caused by a bunch of different things. So primary hypertension, or sometimes it's called essential hypertension, is when your blood pressure is consistently above 140/90 milligrams of mercury. It might be a little bit, what's considered high might be a little bit adjusted for age. But it's an increase in arterial vasoconstriction. So over a long period of time, essential hypertension can damage arterial walls, and that can contribute to atherosclerosis. The blood supply to the area is reduced because of that vasoconstriction. And ischemia and necrosis of the tissues can occur with loss of tissue function. So lots of different things can contribute to primary hypertension. So a lot of times it affects the kidneys, and the kidneys are going to secrete renin and aldosterone to increase blood volume and increase peripheral resistance, and that increases our blood pressure. So it's sort of this cycle that can end up causing damage to arteries, damage to kidneys, and ischemia and necrosis of tissues, which can cause a lot of problems, a lot of other problems. So secondary or resistant hypertension results from renal or endocrine disease. So because kidneys are very involved in that blood pressure control system, if you have kidney disease, you're not going to have the same control. Endocrine disease can also cause secondary hypertension, like a benign tumor of the adrenal medulla, because you're getting too much epinephrine secreted. The underlying problem has to be treated in order to reduce blood pressure. So for essential hypertension, they treat the blood pressure. For secondary hypertension, they have to treat the underlying problem. So we've seen that a lot in other disorders, is whatever underlying problem is causing the disorder, that has to be treated first in order to make it better. There's also malignant or resistant hypertension, which is uncontrollable, severe, and a rapidly progressive form with many complications. The diastolic pressure is extremely high in resistant hypertension, and a lot of times people have to be hospitalized to get it under control. So that's pretty dangerous and cause a lot of problems. So the areas most frequently damaged by hypertension are the kidneys, for obvious reasons, the heart, the brain, and the retina. Those are all pretty important areas, right? It's all unreplaceable things in our body, so we really don't want them to be damaged. So predisposing factors for hypertension, the incidence of hypertension increases with age. Men are affected more frequently and more severely, but that's not to say that women aren't affected too. The incidence in women increases after middle age, like a lot of things. Darn. So one of the reasons why a lot of the heart disease risk factors increase after middle age for women is because estrogen is cardioprotective. And once your body stops making as much estrogen, then you lose the protection, basically. Genetic factors can definitely affect hypertension. Sodium intake, excessive alcohol intake, obesity, smoking, or prolonged or recurrent stress. So even I was reading a thing that said even one cigarette can increase your blood pressure and your heart rate. So there you go. So for treatment, I mean, hypertension doesn't have a lot of symptoms. It's frequently asymptomatic in the early stages. And the initial signs can be vague and nonspecific or even non-existent. Sometimes a morning occipital headache, fatigue, malaise. Essential hypertension is usually treated in steps: lifestyle changes, reduction of sodium intake, weight reduction, reduction of stress, and then it goes to drugs. So the drugs that are most commonly used are diuretics, like hydrochlorothiazide is one of the most common diuretics used to treat essential blood pressure. ACE inhibitors, one of the most common ones for that is lisinopril, and then drug combination. So a really common drug combination for treating hypertension is a pill that includes both lisinopril, which is an ACE inhibitor, and hydrochlorothiazide, which is a diuretic. And the two in combination are used to control someone's blood pressure. When people are on these drugs, their electrolytes need to be monitored, because if you're taking a diuretic, you're losing more water, you're losing more sodium. So you have to monitor your sodium. You also have to monitor potassium and other electrolytes. So it's important that people work with their doctor to take care of these things. So hypertension, of course, can cause problems in all those important areas. It can also predispose you to atherosclerosis. Peripheral vascular disease is So cardiovascular disease is the arteries of the heart, or coronary disease. Peripheral vascular disease is a disease in arteries outside the heart, so every other artery in our body. There's an increased incidence of peripheral vascular disease with diabetes. The most common sites are the abdominal aorta, carotid arteries, and femoral and iliac arteries. It's diagnosed with blood flow Doppler studies and arteriography. I can't say that word. It's a measurement of the size of the limbs and the blood volume in the organs or tissues. It's a radiology test. So good luck pronouncing that. I'm not even going to try today. I don't expect you to be able to pronounce or spell that, but just know that there are imaging tests basically that they do to diagnose peripheral vascular disease. So the signs and symptoms are increased fatigue and weakness in the legs, intermittent claudication, which is leg pain that's associated with exercise that's caused by ischemia in the muscles. So you get muscle ischemia because your arteries are narrowed and you're not getting as much blood to the area. You can also have sensory impairment with tingling, burning, and numbness. Peripheral pulses distal to the arterial occlusion will be weak. So if you take someone's dorsal pedal pulse, it might be weaker than their radial pulse. The appearance of the skin of the feet and legs changes. So marked pallor or cyanosis, which is a bluish tinge. The skin is dry and hairless, and the toenails get thick and hard. So sometimes people have these symptoms and then they're tested. Then they get the imaging to test for the peripheral vascular disease. So it's treated by maintaining control of your blood glucose level, reducing your body mass index. So we're starting to see a common theme here. Reducing serum cholesterol level, platelet inhibitors or anticoagulant medications, and that's to prevent plaques from forming. Cessation of smoking, another one on the theme. Increased activity and exercise, yay. Maintaining a dependent position for the legs improves arterial perfusion. When we get to the venous side, so on the arterial side, we want the legs down. With venous insufficiency, we want the legs up. So it's good to know the difference. Peripheral vasodilators to increase the diameter of the arteries. Observing the skin for breakdown and treating any skin issues promptly, because you can end up having wound issues, and wound issues can develop gangrene, and then your leg gets amputated, and that's no fun. So you can have wounds develop from arterial or venous problems. So an aortic aneurysm is a localized dilation and weakening of the arterial wall. So the aorta is huge, right? It's huge. And so if it's weakened and we've got all the blood going out from the heart pushing against it, then that could be a problem. So there's a defect in the medial layer of the artery, and there's some different shapes of it. I don't expect you to know the individual shapes, but you can have, if you have an aortic aneurysm that bursts, that can be a life-threatening situation. Sometimes people with connective tissue disorders have problems with an aortic aneurysm, or especially dissecting aortic aneurysms. So that's definitely something that you should know. Aortic aneurysm is caused by atherosclerosis, sometimes trauma, sometimes syphilis or other infections because it weakens the artery wall, congenital defects, or congenital disorders like connective tissue disorders. Signs and symptoms, so they call it a bruit, which can be heard on auscultation. So you listen to it and you hear a blub you hear a blurb in the aorta. Sometimes when you palpate the abdomen, you can feel the aortic pulse. Sometimes they're asymptomatic. until they become large or rupture. So the rupture can lead to moderate bleeding, but usually causes severe hemorrhage and death. So not a good thing. Although I have worked with people in the hospital who survived an aortic rupture. So if you get immediate care, you might survive it, but it could cause bad enough hemorrhage that you die from it. So usually it's imaging that diagnoses it. It shows up on radiographs, ultrasound, CT scans, and MRIs. The treatment is to maintain blood pressure at normal levels, prevent sudden elevations caused by exertion, prevent stress, coughing, and constipation, and surgical repair of the aneurysm. On to the venous side, varicose veins are irregular, dilated, tortuous, I love that word, areas of superficial veins. There can be a familial tendency if you have increased body mass index, parity, which is number of times you've given birth, and weightlifting are risks. I've actually seen some pictures of varicose veins on like Olympic weightlifters' legs. They're crazy. But it puts a lot of pressure on the veins, and that's where you get it from. They appear as irregular, purplish, bulging structures that you can see on the outside of the leg. Some people have like just a little varicosity. It's not something that needs to be treated, but sometimes it does need to be treated. You beyond surgical treatment, the conservative treatment is elevating the legs, wearing support stockings, avoiding restricted clothing, and crossing legs that puts more pressure on the veins. So thrombophlebitis and phlebothrombosis sounds the same, doesn't it? Thrombophlebitis is where a thrombus or a clot develops in an inflamed vein, like an IV site is a common place for a thrombus to develop. Phlebothrombosis is where the thrombus forms spontaneously in the vein without prior inflammation, and it's more loosely attached. So the factors for thrombus development are stasis of blood or sluggish blood flow. So like we talked about the effects of immobility, blood stasis is one of them. So if you're immobile, that can be a factor for thrombus development. Endothelial injury, or increased blood coagulability. So if your blood is thicker, it's more viscous, it's more sluggish, and then you're immobile, you're setting yourself up for clot formation. So signs and symptoms can often be unnoticed. It can be aching, burning, or tenderness in the affected legs. You can have systemic signs like fever, malaise, leukocytosis, like almost like you have an infection. Sometimes there is a diagnostic test that's called the Homan sign, where you have someone prone with their feet hanging off the edge of the table and you squeeze their calf, and it elicits pain, more than just the pain of being squeezed. And the complication is that clot could break off and go to your lungs for a pulmonary embolism, or to your brain for a cerebral embolism, so that's not good. The treatment is preventative measures, exercising, elevating your legs, anticoagulant therapy, sometimes surgical intervention. They'll go and put a little filter in to catch any clots that break loose. So a DVT can be a contraindication for soft tissue mobilization or some of the manual treatments that we do in physical therapy. So if you suspect that your patient has a DVT, that is definitely something to send them right to their doctor to get diagnosed.